Mary Campbell from the Department of Healthcare Services. So I'll just touch on the largest adjustments that we're seeing in our May estimate. The biggest single change being the updated caseload. With the May estimate, we're able to use data up through January, whereas for November, we only had data through July. So what we're seeing for both current year and budget year are slight increases in caseload over the governor's budget. For the current year, we are projecting a 1.3% increase from governor's budget to a total of 12.1 million average monthly beneficiaries in the Medi-Cal program. And for budget year, 1.7% higher than the January budget, projecting 12.4 million beneficiaries on an average monthly basis. Another significant change relates to the estimates for the implementation of the President's federal immigration order. We are currently now including the costs of the increased caseload and increased services for these populations who would now be enrolled in full scope Medi-Cal. We are approximating about 100,000 individuals who would be enrolling in Medi-Cal at full implementation. We're assuming enrollment starts in October and that there would be a 12-month phase-in. In total for the budget year, we are estimating the total cost of coverage for the population being about $70 million, with $29 million being costs already being spent on limited scope programs, so a net cost of $41.5 million total funds, or $33.2 million general fund. On an annual basis, we are assuming a total fund cost after offsetting for the limited scope costs currently being spent, $206 million total funds and $165 million general fund. Another significant adjustment relates to the federal approval of the enhanced FMAP for the CHIP program. The increase will begin in October 2015. It's a 23 percentage point increase in the FMAP. Our current budget year reflects a partial year, 3/4 of the general fund offset from the increased federal funding of $381 million. We anticipate that annually that will be $650 million. And then finally, the last significant adjustment relates to our managed care plans rate increases. In January, we budget a placeholder increase as we don't have rates at that time. The projected increase came in lower at 1.6% versus the 3.6% that had been included at the January budget. Happy to take any questions.
DOF? LAO.
Amber DG, Legislative Analyst's Office. With respect to the proposal related to the President's executive actions, we find that there is significant legal uncertainty as to if and when the executive actions may be implemented. As such, we recommend the legislature weigh the trade-offs of using the proposed resources for this purpose. While it's possible that the executive actions may be implemented and there may be costs accruing for 15-16, it's very uncertain, and this takes away from the resources that could be used for other legislative priorities. Further, if funding is included for costs associated with the executive actions in the Medi-Cal budget, we recommend the amount of general fund be reduced because we find the phase-in is likely to take longer than the 12 months that were assumed in the estimate, and we find that the amount could be reduced by up to 50% or $25 million general fund.
Thank you. Any comments or questions from members of the committee? Let's go to public comment.
Good afternoon, Ronald Coleman here on behalf of the California Immigrant Policy Center. Happy to be here on our lobby day with hundreds of immigrant families that are dedicated to this issue. We certainly appreciate the investment from the administration in this area and that the governor has followed existing law and regulations to ensure that we continue the long history and tradition of including all lawfully present immigrants in full scope Medi-Cal. I think that this certainly will bring access to health care for about 101,000 individuals, but we do need to finish the job. I think that certainly we know that there is a big population of folks who are undocumented and uninsured, about 1.4 million people who will remain uninsured. However, because of the president's actions, we do expect a large number of those individuals to be able to move into deferred action, which may make them eligible for Medi-Cal. But with that said, for 2 cents on every dollar that we're already spending on Medi-Cal today out of the general fund, we can finish the job this year. So again, we appreciate continuing existing law and tradition around lawfully present immigrants, but we do ask that we think about those who are undocumented and uninsured. Thank you.
Beth Capel for Health Access California. The estimate you have before you from the administration is both too high and too low. It is too high in that it will be 6 months after the president's action goes into effect before people are granted deferred action. Thus, it will not start in October, even if the court acts tomorrow. It is too low in every other respect. The administration underestimates the percentage of people who succeed in getting deferred action who apply for it. They underestimate the income of those, the income of those who are undocumented, saying that only 44% of them are in the Medi-Cal income range. Recent on-point analysis by the University of California, Berkeley, and UCLA found that 66% were in the Medi-Cal income range, not surprising for someone who lacks a work permit. Literally on every factor on which their estimates are based, they underestimate the number of people who will be eligible for coverage and are likely to enroll. We'll provide more detailed comments to the administration and to the committee. Thank you.
Good afternoon. Janice Canallen on behalf of the Children's Health Coverage Coalition, including the California Coverage and Health Initiatives, Children Now, United Way, PICO, the Children's Partnership, and Children's Defense Fund of California. Our coalition strongly believes the federal CHIP bump funding should be reinvested in children's health, including increasing reimbursement rates for primary care and dental care providers. Medi-Cal rates, as you know, are some of the lowest in the nation, 75% of the national average. We know this affects access because providers are less likely to see Medi-Cal and Dental-Cal patients. We also believe the state has a duty to enroll the remaining 160,000 eligible but unenrolled children. We believe some of the CHIP money should go towards reaching the poorest and some of the most vulnerable children in our state. Thank you very much.
Hi, good afternoon. My name is Joseph Villela on behalf of CHIRLA, the Coalition for Humane Immigrant Rights of Los Angeles. When I echo the comments from my colleagues as it relates to the estimates of LAO, we strongly believe that those are underestimated, given that the current DACA number of folks that are applying is more than 50%, and so we assume that that's going to happen the same thing with DAPA. Furthermore, we also feel that the legislature needs to start investing more in ensuring that those who are insured and are left out of DAPA are included in the have access to healthcare that way. It's more efficient for our state, but then also is more humane. Thank you.
Linda Way with Western Center on Law and Poverty. We believe the May Revise makes a positive step in including the President's executive order on immigration in its estimates. It's important to note that this does not expand Medi-Cal, but rather it includes in those who are already eligible under current law.
Kimberly Chen with the California Pan-Ethnic Health Network, CPEN. Want to echo the comments of our previous speakers regarding the inclusion of funding for those newly eligible for DACA in the new DAPA category, covering them in the way that existing law already covers folks in deferred action. Also want to echo the comments of my colleagues regarding the estimates and encouraging folks to revisit that number. And of course, reminding that the job isn't done yet and there's still much more that needs to be done with covering the remaining uninsured. Thank you.
Mr. Chair, members, Megan Allred on behalf of the California Dental Association. Regarding the CHIP funding, the governor's budget estimates $381 million in savings for the state, and we believe that the money should stay in the DHCS budget as opposed to going to the general fund, and specifically be allocated to children's dental services to address the seriously broken Dental-Cal system as outlined in the legislative audit from last fall. Thanks.
Member questions? Mr. Chair.
Thank you, Mr. Chair. Similar to the last speaker, the savings that were described, it just seemed to me that the good fortune of having 380 some million, saved because of a higher federal drawdown was an opportunity for us to reinvest that money in a very similar program. And while I certainly agree that Dental-Cal is one that is worthy, I was thinking of others that are similar Medi-Cal rate reimbursement as a start, as well as this issue with the clawback for the DP NIFs, and so that hospitals that run nursing facilities don't have to close, or that we wouldn't have the ability to treat those who need those services, and wanted to hear your thoughts and what the department has discussed about reusing those savings in a way that allow us to meet other very critical needs.
Yang Lee with the Department of Finance. So general funds are just a general pot of money, and for the May revise, what the savings that we have achieved through this CHIP enhanced FMAP are just used for other priorities for the administration, such as education, the reserve, or paying down debt.
I understand, and I understand that the priority, the policy, and the practice has been that when there are savings, they go into the general fund. Mm-hmm. I'm making a case, and you can say that you came, the committee beat you up over this, and that the case is that we take the savings from a program like CHIP, right, Children's Health, and that we say this is an opportunity for us to use these savings for other programs that have a need. And if you really needed to, you could even tie it to, for as long as we have the saving. And if we lose the saving, then obviously the conversation should start all over again. But from my standpoint, if we're looking at Medi-Cal reimbursement rates, if we're looking at Deni-Cal programs, if we're looking at programs to nursing facility programs that serve folks with crises and critical health needs, the savings creates an opportunity. So from the standpoint, at least from the chair, you can go back and tell folks that we ask that you reallocate the money in similar ways and not just put it in the general fund. And we want to hear back a report real soon, before Thursday, before we have to vote on priorities. Thank you.
Jennifer Lopez, Department of Finance. So the May revision includes for county administration an additional $150 million augmentation on top of $240 million, which was included at governor's budget. This brings county administration to a total of additional funding of $390 million. The administration did not use a different methodology to calculate this. The $150 million augmentation is the same amount provided to counties in 14-15 at governor's budget. The administration recognizes the challenges we've had with the CalHERS systems, and that county administration, county eligibility workers are having to do some manual workarounds on some of the application processes. However, the system, CalHERS system, has improved and will continue to improve over time as we've briefed you guys on the changes as outlined in the CalHERS 24-month roadmap. Therefore, the administration provided an augmentation to the counties consistent with what they've received in current year. Thank you.
Department of Finance?
That was the Department of Finance.
I'm sorry. DHCS. Let's go back to DHS. That's okay. So we can be flexible. Go ahead. I just got to keep up. Go ahead.
Just to add to my colleagues' comments, in terms of the budgeting methodology, and then just to also touch on timeframes for making improvements, additional improvements with the CalHERS system. So in terms of the new budgeting methodology that was enacted into law, we realistically believe that given the challenges that we currently have with the workarounds that are still in place, and then in anticipation of additional improvements in terms of programming for the CalHERS system, we do not believe that the new budgeting methodology would be appropriate for implementation in 16-17. But we can certainly get the pre-planning work underway in preparation for that, and we anticipate it will be ready within approximately 18 months. In terms of improvements that can be made in the CalHERS system sooner than what is identified on the 24-month roadmap, as was explained by my colleague, Ms. Lopez from Department of Finance. Again, the 24 roadmap has served as a planning tool for us, recognizing and building upon the lessons learned from last year when we were trying to do too much too soon and not allowing enough time for planning and policy decisions to be made, and then having time for the respective systems that have to interface with CalHERS in terms of the design and the testing of those changes in CalHERS. So again, in terms of the 24-month roadmap, we had made some adjustments in terms of priority setting, but with those adjustments and priority setting, we also then had to defer additional programming, and those deferrals included Medi-Cal plan selection as well as what we call consumer protection programs. So we recognize and understand where individuals would like to see us make changes sooner, but given the complexities of the programming and the interfaces and all the systems that are potentially impacted, we do not believe that it is appropriate without the appropriate planning and sitting down at the table, both with our joint sponsored Cover California, as well as our partners with the counties and the SAWs in making those changes to the system. And I welcome any questions that you may have. Thank you.
Thank you. Elio? Okay. Nothing from Elio. I did have a quick question. Was there a workload study done?
There has not been a workload study done.
Okay. Were there workload estimates used to drive this budget allocation?
The 150 is just consistent with what we provided in the current year, so there is no other methodology for it.
Okay, so there was no estimate of 14 to 25 minutes per case that helped drove the budget?
Not for this cost estimate. That was something we worked on, but we didn't end up using that for this, so for the 150 augmentation. So we just held it flat, consistent with what we budgeted for our governor's budget for the current year.
Okay. Was there any input from the workers who are doing this work before coming up with the budget allocation?
So we did talk to CWDA. We talked to them, we discussed it with them, but if we're looking, but like I said, at the same time, this 150 does not include any kind of new methodology or so. We just held the funding flat compared to what we provided in 14-15. It was not, pretty much, it was not used to determine this 150.
Okay, thank you. Let's go to public comment.
Thank you, Mr. Chair and members. Kathy Sunderling with the County Welfare Directors Association of California. We're really surprised to be here asking you for additional funding and saying to you that the funding that's being provided is not enough, because we've been working really well with the administration for the last few years as we worked into the Affordable Care Act implementation. We had a model that we jointly vetted that drove the $240 million that's mentioned as the initial implementation funding, as well as the current year amount of $150 million. You've heard in prior hearings that we from the state and the CWDA have pushed the counties really beyond the breaking point, and the counties have had to push their workers beyond the breaking point. And we've worked incredibly hard to hold this program together, despite the fact that CalHERS has often been more of a hindrance than a help, and despite the fact that the caseloads have been tremendously higher than what was originally anticipated. So we were really surprised when a few weeks ago, the conversations turned to what was a proposed new budget methodology that we'd had no involvement in, that involved some cases being believed to be able to be done, intake case management, and the annual redetermination work for the 14-minute figure that you asked about in your question. This would have produced an amount of zero for us, because it actually indicated that counties needed no additional new funding to be able to sustain the level of customer service, program integrity, and administer the program on the state's behalf. This obviously makes no sense. It demonstrates a complete lack of understanding of how Medi-Cal works. We appreciate that there's $150 million now provided in the May revise, but it's not enough. The $150 million that was provided in January is intended to be a 6-month number. Annualizing it, we requested $300 million total funds. Counties are not going to be able to sustain the workload. They're not going to be able to sustain the staff that they have today doing the level of work that's required of them. CalHERS has improved. We do have the 24-month roadmap, but better isn't good. The system is still not working to the level that would enable us to do the work for the level that's proposed in the budget. We still have to check every single case as it comes over from that system because of errors that are run very commonly creating duplicate cases, looking at income incorrectly, making people eligible when they shouldn't be, making duplicate cases, all of which get capitation rates paid for managed care and increase the benefit costs if we're not there to catch them. We will not be able to do that level of program integrity. We will not be able to continue to do renewals on time. We'll have to just get people in the door, get them enrolled, and do what we can for the case management and the cleanup as we can do it. We saw this happen about 10 years ago. The funding was cut for a number of reasons earlier in the last decade, and we did see caseloads go up. Ultimately, the Davis administration proposed to give us tens of millions of dollars to save hundreds of millions of dollars in increased benefit costs. We're concerned that that's going to happen again, that this is a really pound foolish and we think not even penny wise decision that's being proposed. Finally, just with regards to the budget methodology, we are asking the enactment of trailer bill language to update the statute that exists today. We are concerned that CWDA has not been included as a partner. The budget agenda, for example, mentions that a contract has been entered into with an entity to assist in the development of the budget methodology. We were not aware of that until we read it in the agenda today. And so we were not included in the development of the scope of work for that activity. We don't know who's been selected. We've not had any meetings regarding the budget methodology. This was something that the legislature intended be done in consultation, in conjunction with CWDA and with the counties and with representatives of county workers, because the workarounds are tremendous that we're going through. I don't think the administration can have it both ways. I don't think that they can say, we don't think you have enough work and you've not justified enough work for us to give you that $300 million, but we don't want to do a time study to see how much work you're actually doing because it would be too expensive to fund. I don't know which way they want it, but you can't have it both ways. Thank you for your time.
Good afternoon. Tia Orr on behalf of the Service Employees International Union. For purposes of not being redundant, I would just like to reiterate a lot of the comments that Ms. Senderling stated. Specifically on behalf of our workers statewide, we are definitely surprised and if not floored and slighted by the proposal by the administration. I think like the county welfare directors, we had a working partnership with the Department of Healthcare Services as well as the administration to make sure that funding was going to be appropriated in a level necessary for us to be able to do our jobs. We agreed in good faith not to do the workload study with the understanding that if the workload study was done with all of the errors and technical difficulties in the system, it would require the state to pay a great deal of money to counties to administer the work. We agreed to push the workload study behind, pushed it beyond while counties were funded for the necessary levels as we are today. Unfortunately, this proposal, causes us to be woefully short of that. I don't know who they spoke to, and I think it was an appropriate question, Assemblymember Bonta. They have not spoke to our workers. I brought 3 workers here today that can tell you about their experience in the county, and they can definitely challenge the 14-minute time that was actually estimated to 21 minutes is actually just unheard of in counties right now. Thank you.
Good afternoon. Farrah McDade-Ting for the California State Association of Counties. I'd like to associate my comments with the previous 2 speakers and note that while we do appreciate the at least $150 million, it falls far short of what counties need to continue to administer this program. I will remind you that with county help, California has led the nation and been the shining star of ACA implementation, getting people either eligible for Medi-Cal or the CalHERS system, working on the exchange part. Without the county's help, that would not have happened. This funding falls far short. We have 3 million more people on Medi-Cal and more people coming through, and we feel it's wholly inadequate. We also support CWDA's proposed trailer bill language to do the time study in conjunction with DHCS and work on that project in the next year or so. Thank you.
Roseanne Berthrana-Rechka. I'm a Medi-Cal program coordinator from the County of Santa Clara here on behalf of SEIU. I would say that I'm disappointed by the estimate of $150 million additional funds. Even if you based it on last year, we ended up with $300 million because of the massive workarounds and the system functionality that does most of my job is I deal with the policy and the system functionality. And I would please somebody come and sit with us and look at what we have to deal with every day. 1 month, we got 10,777 duplicate applications in the county of Santa Clara. 1 county out of the 58 that we have to sort through all before we can even figure out which application we should work. The workarounds are massive. The system functionality, the administration in a recent CalHERS hearing a couple weeks ago admitted that they said that we had just achieved system stability and we were working on programmatic stability. In regular talk, to me that means the system doesn't crash anymore, but we're not sure what you're going to get when we put the information in. And that's the realities of what we're dealing with here. And we need additional funds in order to be the first line of defense, in order to make sure that we don't have people on Medi-Cal who aren't supposed to be on Medi-Cal, and that we serve the community in the way that they deserve to be served. Thank you.
Let me just remind folks of the 30-second rule on comment.
Good afternoon, Mr. Chair. Martha Guerrero, representing the Los Angeles County Board of Supervisors, and we are also extremely disappointed with how this was funded. It is significantly underfunding all the hard work that our eligibility workers are performing at the county level. Our Board of Supervisors have been monitoring this closely, have observed how CalHERS is a dysfunctional system, and our workers are having to do everything to fill in those gaps. And I have a letter here that I wanted to make sure you had a chance to see, so that you can understand that we are asking for increased funds so that we can continue, our workers can continue to do all their hard work and through their dedication, and have the Board of Supervisors continue to back them up so they can get this job done right at the local level. Thank you.
Good afternoon. My name is Raymond Cadena. I'm an eligibility worker from Los Angeles County. I wanted to say about the problems with the system, the problems we're having as eligibility workers. Reviewing a case and fixing a case for Medi-Cal can take anywhere from 45 minutes to even a couple of hours, depending on how much work goes into it, and to properly review every single item you're inputting. Another thing, if you ever do a caseload study, we welcome you to come to LA County, where eligibility workers have in excess of 1,000 cases each, and in some cases up to 2,000 on the bilingual section. Okay, thank you.
Thank you.
Hi, my name is Carlos Tovar, and I'm an eligibility worker in LA County. I'm also a shop steward for Cut A for the district. And I really believe that the working families deserve better. And with additional 150, that would really help out the families there that are most in need of our services. And with the regards to that 21-minute, it's not happening. Not in LA County. Thank you.
Thank you.
Tama with Health Access California. We strongly urge the committee to take a thoughtful look at this issue and make sure that the counties have adequate resources to do the eligibility work required to make access to Medi-Cal a reality for all the recipients that are eligible for this program. Thank you.
Linda Way with Western Center on Law and Poverty. We're not experts on the numbers, but we are aware of the issues that county workers face and the backlog in terms of Medi-Cal applications and renewals. We think it's important that determinations be made in a timely manner. Thank you.
Thank you. So could you perhaps address some of the issues that were raised, particularly around the $150 million augmentation being a 6-month augmentation, and then if that were annualized, it would be $300 million. Also about the workers that were consulted or maybe not consulted, and then also about a workload study, using one to actually inform this budgeting process, since one hasn't been done.
Jennifer Lopez, Department of Finance again. I'll answer the first part, and then I'll defer to my colleagues of Healthcare Services. The $150 million was a current year estimate. However, we know that CalHERS has improved and will continue to improve. In fact, every few months there's system improvements that are being deployed. So we took that into account and that's part of the reason we kept their current year funding constant. The county is on point to spend that if you add the additional 240 and the 150, it's a total funding of $390 million. They're on point to spend that. So we weighed that there's going to be some efficiencies, and it's going to get better. It's gotten a lot better since the first open enrollment period. To address if we had spoken with county eligibility workers, in fact, Department of Finance, through help through CWDA, we actually went to 2 county eligibility offices. We went to Stanislaus County and Yuba County. Sutter County. Thank you.
Stanislaus and Sutter?
Yes. Stanislaus and Yuba.
You said Stanislaus and Yuba earlier, so if you were right earlier. Yeah.
Stanislaus and either Yuba or Sutter.
It's Stanislaus and Yuba.
Stanislaus and Yuba. Got it. Okay.
Okay. And then Renee Muller, Department of Healthcare Services. In terms of the budgeting methodology, we believe that we need data to help inform the budgeting methodology pursuant to the enabling statute. And we believe until we get to a more steady state, we won't have accurate data to help inform that methodology. Thank you.
Thank you. My understanding is that there a workload study could have been done, but it was specifically held off on, and because of some understanding of what the budget might be, using the $150 million as a 6-month figure, and then it would be annualized. I'm just trying to make sure I understand that. I'm hearing that there's CalHERS efficiencies. Are you saying there's CalHERS efficiencies to the tune of $150 million? Or am I just looking at that wrong? Please help me understand that.
In 14-15, we had a backlog with CMS. We had a backlog of new applicants. Currently, the state does not have a backlog. And we also took into account that we do not currently have a backlog of new applicants waiting to have their applications processed. And we took into account the efficiencies in the CalHERS system.
Thank you.
You're welcome.
Did you want to address the study, workload study issue? It sounds like, it can be done, and that can drive the budgeting process.
Well, part of the enabling statute did require that in order to undertake the time study, there had to be a proposal that had to be developed and submitted to the legislature in advance of using it. And that methodology would be used no sooner than 15-16 for the budget year for county admin. So again, we reiterate the need for us to have a steady state in terms of the workload and the work efforts, and then also meet with appropriate representatives, both from the department and the counties, in terms of both fiscal and policy staff, in terms of identifying what would be the data elements that we would use to help inform what that budgeting methodology would be, including time studies of the work that is being done by the county eligibility workers.
Thank you. Please, public comment.
Kathy Sunderling with the County Welfare Directors Association. While it's true that there's no pending case backlog, it's turned into a work backlog for counties. Most of those cases that were pulled out of the backlog were batched into the state system, into temporary aid codes that the counties now have to go work individually each case. Some of the cases couldn't even be batched because they had so many issues with them, and counties have had to manually work those cases individually, doing workarounds. What we typically have to do is force coverage for these individuals in our state's med system, and then put them on a list so that when CalHERS, whatever the issue was with CalHERS, is fixed, we're able to go back to that case and work it again. So it's getting worked in a batch. Sometimes it's also then getting worked temporarily to just get into coverage, and then it's getting worked a third time to finalize it. But for many of those cases, we can't even do that yet because the issues in CalHERS haven't yet been corrected for us to be able to go do that. For example, we are not able to yet deny applications in CalHERS. Our workers cannot do that. They have to put those individuals on a list. That's supposed to happen in July, late July, but we're not even sure if that's going to happen on time. We're all working toward it being timely. The concern with CalHERS fixes is that often they introduce additional defects that we then have to go through and work through and fix. So the 24-month roadmap is very helpful. We agree that it will make corrections to the system. It may also introduce more problems, and the 24-month is a bit of a misnomer. It's going to be a rolling forward issue for at least a few more years as we get the system into proper working order. Thank you, sir.
Thank you. Okay. See no further questions or public comment. Let's go on to the next item. Issue number 3, Drug Medi-Cal Waiver May Revise Budget Change Proposal. Whenever you're ready.
Hi, my name is Marlise Perez. I'm with the Department of Healthcare Services, and I'm here to talk about our proposal for our Drug Medi-Cal Organized Delivery System waiver. So the department requests 13 positions, funding for our external quality review organization, and for training and technical assistance. And these funds will be used to implement and oversee our Drug Medi-Cal waiver, which is going to be lifting up services for our SUD beneficiaries. We're requiring counties to submit a county implementation plan, a fiscal plan. There's a new providers appeals process. We are crafting the system based on the ASAM criteria, which is the American Society of Addiction Medicine, which places our beneficiaries in the proper level of care. We are also going to be requiring that our residential treatment facilities receive an ASAM designation, since we're putting so much work in ensuring that our beneficiaries receive the proper level of treatment. We want to make sure they're actually receiving that at a proper facility that's designated based on the ASAM levels. We are also going to be working with our tribal partners. We are adding a phase to the waiver, phase 5. We still have to work with our tribal partners to work out how that delivery system will work. We also have CMS is requiring an integration plan, and also for us to participate in their Innovation Accelerator program to further enhance our services for our SUD population. So all the positions will be working on these activities. We also wanted to provide you with an update on where we are at with the waiver. We are going to be releasing a draft of our standard terms and conditions this week. And we formally submitted to CMS back in November, and we wanted to provide stakeholders with an update. And then we are working on the final stages of approval with CMS. We are going to be receiving a second round of formal questions probably at the end of this week. We have about 2 issues left, and then we're anticipating approval at the end of May or the first part of June.
Thank you. Public Health?